Hello, we're from the Walton Centre Specialist Neuroscience Trust in Liverpool. I'm Stuart Moore and I'm the Director of Strategy. We operate all our services across Merseyside and Cheshire and North Wales on a network basis. So that's neurology, neurosurgery, including spinal, rehabilitation and pain services as well. Got a population of about 3 million. Quite a bit of experience of that, and it's highlighted 5 key obstacles, or to be optimistic, critical success factors. Firstly, it's about the infrastructure to develop and manage that model. It's about the incentives and the disincentives for partners to be part of it. It's about the money, the financial flows. And it's about behaviours, organisational and individual. There's lots of fine words about collaboration, but that can disappear sometimes. And commissioner support, especially when the going gets tough. So we've learnt from that in our proposal. We're going to focus on neurology and spinal services, as those are the largest services and have got the greatest opportunities. Peter Walton, our medical director and consultant neurologist, will talk about neurology, and Paul May, who's clinical chair for the trauma programme of care for NHS England and divisional clinical director for neurosurgery, it's a lot, is going to talk about spinal. Then Julie Riley, divisional director, will talk about what Vanguard would mean for us.
Good afternoon. Hopefully you can hear me. I'm the medical director, but more importantly here, I'm a consultant neurologist still. And unfortunately, or fortunately, don't know, there are less than 600 of people like myself. So there are very few of us, and yet there is a huge population of patients with long-term neurological conditions. It could be 8 million, depending upon what definition is used in England. And they need care in the community, and they ain't getting it. Furthermore, they have crises and exacerbations of their condition, as we've heard, and this leads to 17% of attendances at GPs, 10% of attendances at A&E departments, 20% of acute medical admissions, and even if you take out stroke, that's still 10% of acute medical admissions are neurological. Now, if you put this together, you can see major challenges in terms of access, equity of access, because of those 600, they're lopsided very much towards London and the southeast. So huge problems with equity of access and avoidance of admissions, of which there are 250,000 in England alone each year. So these problems and the inequalities have been documented repeatedly across England by the National Audit Office, the Neurological Alliance, and most recently, Public Health England. So what does the Walton Centre do now? Well, for the last 23 years, for this population of 3 to 3.5 million, we've run this hub and spoke model. Now, the strength of this, or the secret of it, is the strength of the spokes. And I would emphasise this. This isn't about the centre, this is the strength of the spokes. And this is to all 14 DGHs in our patch. Furthest is 93 miles away, or the Isle of Man with a flight and everything else. And we provide outpatient clinics, we provide ward referral sessions, and we provide input into the medical assessment unit. We guarantee the clinical governance, the accountability, and the electronic connectivity. Furthermore, we guarantee the supply, and that is the essential thing. We guarantee the supply. We deliver tertiary level neurological services to our patients equitably in every DGH 3 to 5 days a week. So what do we want to do? Well, we're already high performing in Cheshire and Mersey, but in short, we want to take the services to the DGH 7 days a week, and we want to take our services out into the community. How are we going to do that? Well, telemedicine 7 days a week for the acute services, enhanced medical and neurological advice lines, ensuring implementation of the pathways we've drawn up with our patients, and increasing the depth and extent of the advanced neurology nurses that we put in between the specialist care and the community services. So over to Paul May.
Thanks, Peter. The NHS spends about £2 billion a year on back pain, and about 300 million on spinal surgery, and there's a 7% year-on-year increase in activity and cost. There are considerable variations in practice. Many providers of NHS services are in the private sector without any commitment to audit, outcome, or quality assurance. The majority of providers do not or are not compliable with the 18-week referral to treatment target, and many patients are waiting for much longer periods than that. If you can't have equitable care, replicability, and reduction in variation unless you've got meaningful, validated outcome data led by the patient, patient-reported outcome measures. For the last 8 years, we've had a universal, verifiable, European-based Spine Tango patient-reported outcome data set for now a cohort of 20,000 patients with spinal surgery, and it's a 2-year follow-up based on patient-reported outcome measures. For the last 2 years, we've led the National Neurosurgical Audit Programme, which has been adopted by NHS England and gives consultant and unit-based mortality rates for elective and non-elective neurosurgical procedures, and is adopted by all the 24 adult neurosurgical units in England and the 6 paediatric neurosurgical units. 12 months ago, we were asked to support a local district general hospital with a significant waiting list issue. And we took on 100 patients, many of whom have been waiting for more than a year for their spinal surgery. We conducted a review and revalidation process, and the outcome of that was that only two-thirds did not require the original planned surgery, which was significant benefit to the patient, significant benefit to NHS. However, that was a profoundly challenging situation. It was very difficult at all levels in terms of issues of predatory perception, difficulties in challenging clinical behaviours, pre-established clinical behaviours without evidence base, and more importantly, the depth and focus and support required for the patients undergoing these changes, moving to a different environment, seeing a different surgeon, not having the original surgery that they thought they were going to be having after 1 year. Really profound changes and really profound requirements for support of those patients. However, having been through that, we've got a positive outcome. We now have a regional MDT with the District General Hospital. We share our work. They all comply. We all comply with National Neurosurgical Audit and Outcome and spinal data. And we are now engaging with the other providers in the region. Our experience and lessons learned have been pivotal in our inclusion in the National Transformation Spinal Programme, which NHS England is leading as one of the 4 pilot sites for this development of spinal networks. Thank you.
Thank you very much. I have questions for the... I've never heard someone speak so fast. I have questions for the Walton Centre. Samantha?
Thank you, Anthony. So why do you want to be a Vanguard? What will it actually bring?
We didn't actually get to that point, did we? Why we want to be a vanguard, we want to implement this quicker than what we're already doing. That will help us with our double running costs, and it will also help us with the funding mechanisms. But I think more importantly for the patient, it'll mean a local access to high quality neurological care. And it would enable us to build on a really good, comprehensive neuroscience service that we've got a track record in delivering.
So can I just push you again? So why do you really want to be a vanguard? Because that's not about being a vanguard. You can do that anyway.
Yeah. Shall I step up on that one? Yeah, there's a few particular things. I think Vanguard would give us access to some of the project resources that I mentioned we need as a critical success factor, some of the support around the making it happen and the change management, the financial flows work that I referred to. I think also actually the credibility with the stakeholders. Paul referred to the challenge that we had with the initial spinal unit. Having a bit of a badge behind us is going to help us with that and working across the patch. So there's quite a number of facets that I think that this would really give us an added impetus to the project.
I think that, dealing with spinal surgery is a big issue. We would like to roll out this to engage with the private providers of NHS services who don't currently, unlike if a patient with a back problem goes to one of the specialist centres or for complex spine or for neurosurgery, they're going to be engaging with a unit that is required and mandated to undertake national audit and outcome programs. If the patient is part of a contract from a CCG neurology within the private sector, there is no requirement for that, and there is no outcome and audit regulation on that exposure, and we think that's wrong.
Thank you. I've got a question here and then the one over here next.
Hi there. One of the requirements of Vanguard is to demonstrate how you would improve the financial sustainability of your healthcare system. Sure. So I wanted to ask you about that. And then just to pick up, so my trust runs a tertiary specialist service that covers 9 DGHs. One of the trusts said, could you come and run a 7-day service for us? And we've managed to do that with them without needing the Vanguard process, just by using joint working between 2 organisations. But could you answer the question about the financial benefits of your Vanguard?
Well, I think from the neurological point of view, I mean, what we have done is that the pilot that we ran for these advanced neurology nurses, we did on the Wirral, which, as some of you may know, it's got water on 3 sides. It's a great place to run a pilot. We showed that it reduced the GP contacts, it reduced the admissions, it reduced the A&E attendances. It also was great for patients. Patients loved it on the patient assessment. So from that point of view, we've demonstrated that part of the model saves money. We also know that repeatedly it's been shown that non-specialists, when these patients are admitted, when there isn't the availability of neurologists to provide their input, these patients stay in much longer and they have lots of investigations done which are unnecessary. There have been repeated studies showing that. So basically it's a no-brainer from the neurology point of view. From the neurosurgery point of view, I'll let Paul speak, but that's this particular project that we did with a certain hospital saved the NHS £154,000.
In general terms, I think there's large volumes of patients on waiting lists for spinal surgery that don't need to be on the waiting list, or the original procedure that was planned or for which they were listed is not necessary. That's going to be a major challenge to the spinal transformation project. I think there are large volumes of patients who are receiving treatment in the from private providers on NHS contracts that are getting procedures and interventions that are not supported by NICE and that have a variable and questionable outcome and for which there's no assessment of the efficacy, audit and outcome and patient-reported outcome measures. So I think there are multiple limbs of significant financial opportunity in this process.
Thank you. Question on table number 25.
Julie Tasker, patient representative, Nottinghamshire. How are you going to link up with the private sector and value their input as well?
That's a very good question, and I think that we have to engage with the significant local providers of that service. I know that the 2 largest providers, not necessarily of surgical procedures, but of interventional spinal procedures nationally, are Ramsay Healthcare and Spire. That's certainly true in the Northwest. They provide a huge volume of service on the basis of CCG contracts. Now, we have to engage through them at the highest level, at the level of the adult neurosurgery CRG, the complex spine CRG, the local area teams, the trauma program of care board in which spinal surgery, neurosurgery sits, through the patient support groups and through the professional organisations, the Society of British Neurological Surgeons, British Association of Spinal Surgeons, and the British Back Pain Society. We have to address this, in my opinion. No, but the whole spinal transformation project is a 3-limbed project. One of the key elements is the spinal Pathfinder project, and the Pathfinder is about that patient journey, the significant number of patients that don't need to get into secondary or tertiary care, in whom the treatment and pathway is so variable from region to region, from district to district, from local area team to local area team. We need consistency. We need patient awareness, combined psychological physiotherapy therapy. We've had a 29 stakeholder engagement led by Charles Greenough, the National Clinical Director for Spine, with all patient groups, professional organisations and providers to devise a Pathfinder project that hopefully will divert and lead the appropriate pathway for patients with back pain away from hospital intervention, hospital appointment, inappropriate MRI, unnecessary or ineffective injection therapy.
Thank you very much. That's the end of questions. Can I have a big round of applause for the Walton Centre?